All right. Hi, everyone. Welcome and thank you for joining us today. My name is Frankie, and I am the Field Education Academic Coordinator at ACAP. I hope that you can hear me all good because my mic is a little bit off. And together with me, we have Danielle Palos, who's a ACAP student representative who will be supporting the session today in the background. So before we commence, I would like to acknowledge the traditional custodians of country throughout Australia and their continuing connections to land, sea, and community. I pay our respects to elders past and present and extend our respect to our youth who will continue to nurture this land and preserve the oldest surviving culture on the planet. So there is a chat function, and I encourage you to acknowledge the land that you're on. I am on Darug land, and I am looking forward to hear where you are connecting with us from today. Welcome. Thank you, Michelle. While everyone's typing, just a little bit of information on housekeeping. So the session is counting towards your placement hours. Therefore, we will be taking random attendances throughout the session. So please make sure that you're staying throughout the session and actively engaging. And a quick reminder to update your screen name to include your full name and the university that you're from so that we can identify you in the attendance sheet. Again, this session is recorded and the materials and recording will be distributed through email after the session. So our presenters today are George Turner and Candice Care-Unger. George is a senior lecturer in the School of Social Sciences at Western Sydney University. And Candice is a social worker and psychosocial therapist from Royal Rehab. So welcome, George and Candice. And I am looking forward to hearing about your journey and what you would like to share with us about sex and social work.
Thanks, Frankie. Thanks, Frankie. I guess our presentation today is going to come in two parts. Myself and George are going to both share some content and then we will, address some of the Q&A questions that you guys had the chance to put in when you were doing your registration and for the event. So thank you for joining us. Like Frankie said, my name is Candice. I'm a social worker and a psychosexual therapist. I work over at Royal Rehab, which is in Sydney, for those of you who aren't familiar. I guess my specialty area is both rehabilitation, working with people with disability, and then in terms of sex, specifically within the disability community. That's where I have chosen to specialise. I guess before we get too much into today's information, I just want to cover the things that we're not going to cover, because I know that you guys had already attended a queer social work lecture a couple of weeks ago. So we're not going to be talking about sexual orientation, gender, and that's not because it's not really important to this work, but it's because you've already done it. So this is going to build on from that. We're also not going to be covering sexual assault and trauma work. That deserves its own hour and a half. So we're going to be looking at today through a human sexuality lens, and then the role of social work in this, thinking about it like a biopsychosocial spiritual model as well. So George and I have very different career paths, but I guess we get a chance to hear a little bit about those this afternoon, sorry. And we've got a Q&A function here. So by all means, feel free to ask questions. We're just going to ask if you just hold them towards the back end. So we've probably got about an hour's worth of presentation, and then, feel free to let them all out. So I'm going to hand over to George, and I'll be back in about 30 minutes.
Wonderful, wonderful. Thank you so much, Candice. I am delighted to be here. Just as a little bit of background about myself, and we may talk about this a little bit in more detail. I am originally from the US. I spent about 15 years in private practice, mostly doing couples work as well as sex therapy. Prior to that, I worked in a variety of sectors, and that includes rehab, addictions recovery. I worked in disabilities, specifically intellectual disabilities, as well as geriatric care. And I did a small little stint at doing school social work. So a wide range of placements and opportunities there. And so I want to do a screen share, and I'm going to jump into the presentation, and I am going to just kind of quickly go through things, and hopefully if you have questions, you will save those or jot them down, and we will have time to have those at the end of the presentation. Okay, and so I'm looking at Danielle. Danielle, can you see my PowerPoint? I'm just
Yes.
Wonderful, wonderful. So today's topic, we labeled this, what's sex got to do with social work? And I guess the short answer is everything. It's everything. It really kind of depends on what your frame is and how you're approaching this. I come to this conversation after years and years of recognizing that my approach to social work really needed to have a sexual wellness lens. And so once I started building that and conceptualizing and putting that together, then it really crystallized the type of social work I did, because I see myself as a sexual wellness social worker, and I see clients through that lens. You know, the question might be, well, George, why sex? What's sex? You know, what does that have to do with anything with social work? I don't see it that way. And I might turn around and say, you know, what does healthy families have to do with social work? What do healthy communities have to do with social work? A healthy client. It has everything to do with social work. And I work with people, so I inherently work with who they are as sexual people, as sexual beings. And I need to be prepared to what they bring into the space, the clinical space, the social work space. I need to be prepared to address all aspects of who they are. And I want them to feel welcome bringing all that into to our relationship. Just like I want to acknowledge who they are as spiritual people. I want to know what their faith belief systems are. I want them to feel comfortable bringing that in. I also want to see the other aspects of who they are as sexual people. And I think being sexually literate, askable, sex positive means that we do better social work. And so if anything, today is really about just turning that lens on a little bit for you to start making the connection and seeing where you are in the process. So here's what I'm hoping to cover. It's a pretty ambitious list, but these come straight from your questions. And so I think, you know, once everything is said and done after today, you will have an answer to these questions, at least these 7 questions. I want to highlight number 6 just before I get started, really. And somebody asked the questions, suggestions for helping the clients feel more comfortable talking about sex. And my suggestion is that you as social workers get comfortable talking about it. Because keep in mind, just like we are assessing our clients, they're assessing us. They're looking to us and they're trying to figure out if A, we're safe. Can they bring all of who they are in the room? And if they read or they get a sense that there's sex negativity as a part of your approach, or that you're uncomfortable, that's when they start to shut down. So if you want to help clients feel comfortable, you need to work on you being comfortable. That's just the quick answer, okay? So typically, what is the sex talk about? What do people typically look at when they're considering sex and sexuality? And I would say that unfortunately, we don't do it very well. We don't tend to really have a sense of how to accomplish this well. And I think we need to recognize the current landscape. What is the current sexuality landscape look like for us social workers? And until we make an effort to change that landscape, unfortunately, it's got a lot of pitfalls. I think we make a lot of mistakes. And I think we're living in kind of a poverty of sexual well-being. Many people think, oh, there's so much sex in the media. And yeah, it's in a lot of ways, the conversation is saturated yeah, in popular culture, but it's also inundated with a lot of negativity. It's a lot of myths, misinformation, and shame and guilt. So I think we as social workers can start to change that discourse, start to change that conversation with our clients. Okay, so let's talk a little bit about some of the common mistakes. I think it's limited in scope. I think one of the first mistakes that we make as social workers is we equate our client sexuality to a behavior. We focus just on a behavior. And the reality is it's much, much more. So hopefully after today, you're going to kind of get a much more comprehensive, nuanced idea of how to look at client sexuality. And I think social workers need a comprehensive, holistic idea of looking at sexuality beyond behavior, okay? Beyond behavior. I think oftentimes we're unprepared. We stumble into working with clients hoping and praying that they won't talk about stuff that we don't want to talk about. Guess what? They're going to talk about it. They're going to bring up all kinds of stuff if you are askable. Again, they're taking the temperature. They're assessing you. And if a client feels like, hey, Candice seems like a pretty cool chick, hey, she seems like I could probably talk about this really challenging conversation that I need to talk about. They're more likely to do that. So we don't want to be unprepared. You don't have to be an expert, by the way. You don't have to know everything. But for me as a social worker, I want to come to the table. I want to be able to work with clients and give them a space that says, hey, I'm here for you. And that includes who you are as a sexual person. By the way, for those of you who are familiar with The Wizard of Oz, I hope this reference doesn't get lost on you, but I do think we need to bring knowledge, heart, and courage to the conversation. Okay? That's knowledge, heart, and courage. I think this is a really difficult, often taboo topic for our clients, for us. And so I think we have to have a gentleness to it. And I think we need to be able to understand how hard this is for our clients. And we may need to go the extra distance to help them. I speak often to medical students and they'll say, well, I'll bring it up if my patient brings it up. I'm like, no, that's not your job. You are a healthcare provider. Social workers also are healthcare providers. We don't just sit back and wait to see if clients are going to talk about abuse and trauma. We ask about challenging things. We ask about difficult things. We walk into really, really hard conversations. And so we don't sit back and just wait to introduce this as part of the clinical landscape, if you will. We've already mentioned this. Oftentimes, I think the second mistake or the third mistake is we reduce this to just the queer talk. And as important as discussing the LGBTQ community is, being a social worker who operates from a sexual wellness lens is more than talking about the LGBT community. Okay, so just keep that in mind. Also, I think if we do talk about this, we tend to focus just on some safe topics. We look at penile vaginal intercourse. We talk about heterosexuality. We talk about reproduction. Those are the safe sex talks to have. And again, those are important conversations, but we have to be mindful that this isn't all of our clients. There's more to this conversation. And so if we only put out there that we're only willing to talk about these topics, then our clients are going to pick up on that. They're going to pick up on that we're not versed or comfortable having some more challenging or difficult conversations that are unique to their life, that are specific to who they are as clients. Also, the 3 Ds: disease, disaster, dysfunction. If there's any conversations, and typically in a medical model, this is what gets discussed. Again, important topics, but it doesn't cover the breadth and the richness of who our clients are. So make sure that you're prepared to move beyond that and look at things beyond just this catastrophizing of sexuality. What if we as social workers actually had conversations and we were prepared to have honest conversations that a sexual life, a sexual experience, a sexual activity, or engaging in lovemaking or being in partnership, it's actually kind of nice. It's fun. What if we brought that strengths perspective, that a client's sexuality is an asset? It's a gift. It's a part of who they are, and it should be a healthy part of who they are that they get to express in a healthy way. What if we were an advocate for that and not just talking about sex is bad? Okay. Again, I think sometimes social workers kind of get sucked into the narrative, the negative narrative that sex is bad, because that's what you hear in a lot of sex education, certain programs, or it's doom and gloom, watch out, be prepared, warning signs, danger, danger. What if we removed ourselves or brought in at least sex positivity to counter that negativity? Let's face it, there's a lot of wonderful, great things about the totality of a client's sexuality. I think sometimes we mistakenly participate in microaggressions. And I think we as clinicians, we as social workers need to be aware when we perpetuate things like shame, when we perpetuate things like only certain people are allowed to have sex. And we need to be aware of how we may be sending messages to our clients that tell them that who they are as a sexual being is not truly recognized and valued within our relationship as social worker client. So what are we talking about? What are we talking about? Well, this is a nice definition. This is the WHO definition, and it's a very comprehensive and it's a wonderful definition that allows me to kind of reconceptualize away from that disease and disaster model. It really kind of opens up this idea of a comprehensive model, a comprehensive definition of how I'm looking at clients. Okay, so if you as a student are wanting to kind of think about how do I want to start practicing from a sexual well-being lens, this is a great start. In addition, I think asking a client, what is it that you see as part of your sexuality? Asking what they bring to their understanding. Are they stuck in shame and guilt? Do they celebrate who they are? Do they enjoy who they are and their partnerships with people? How are they a part of this conversation? And so taking the lead from them can help you kind of start down this road. Finally, in regards to this is a great model that I use, and I think Candice is going to speak about another model, the Plisson model. This is the circles of sexuality and was developed by a social worker in the US, Dr. Dennis Daly at the University of Kansas. And so if you don't know about this model, you really should. You really should. What I like about this model, again, I'm kind of a visual person. So listen, when I was growing up, sex was one thing. It was intercourse. That's what sex was. That's what it meant. And usually it was something that was secretive and you only kind of whispered about. That was the model when I grew up. That's how I was taught. It was something dirty and bad. This model expands that conversation, and it places this conversation in 5 distinct circles. Again, I'm not going to go into this model in depth. I wrote about it in an article, and I'm happy to share that article with you. And I encourage you to read that. But it looks at sexuality from 5 unique lenses. And the best one, or the one that I really enjoyed the most, I gotta take that back. The one that I think is really helpful is the values one, because it says connecting all these is what the client believes, what their culture, family, religion, faith, political, education, all those things, how they see this is really, really important. The other piece that I really appreciate about this model is it recognizes intimacy, and it defines intimacy. Dennis Daly defines intimacy as vulnerability, a willingness to be known, and taking risks. I use that circle with clients all the time. I ask them about how willing are they to engage with me in an emotionally intimate relationship. It's hard stuff. And lots of people aren't very good at it. Lots of people are much more comfortable taking their clothes off than taking the mask off, the emotional mask, to be able to share who they are. That can be really hard for our clients. So this idea of a sexual wellness practice lens, I want you to think about how do I see clients? How do I see clients? And what does that mean for me and the way I practice? And my lens is more than reproduction. My lens is more than penile vaginal penetration. It looks at a variety of things. So here's what I want to talk about real quick. I want to give you 7 reasons why sexuality falls into social work, and for you to think about why it fits here, okay? So first of all, I think sexual well-being is a quality of life issue. And so if you don't know this aspect of your client, I would argue you don't know your client. If you don't know who they're dating, if you don't know how their sex education went as a child, if you don't know their understanding of their body, if it's based in shame or if it's based in pride, if you don't know those aspects, you have a very limited idea of who your client is. And for me, most clients, I think, want to have a fulfilling and full life. And that includes who they are as sexual people, Keep in mind that this conversation, a sexual well-being lens, it's a cradle to grave issue. From the moment we're born and to the moment we die, we're sexual people. Doesn't mean we're having sex, but we're sexual people. And I think that's a shift. That's a shift in this model, this idea, because all too often this model only looks at those people who are of reproductive age, or those people who are wanting to reproduce. And that's a really, really small segment. My 80-year-old mother is a sexual person. She's loved, she's been loved, and she has a right to have her relationship with my father acknowledged by the social worker, the hospice social worker who is with them as he's dying. That hospice social worker has to recognize this woman is losing her lover. This 80-year-old wrinkled woman is losing the man that she slept in a bed with for 50 years. And oftentimes that doesn't get acknowledged, that aspect of our clients. Social work or sexual health is social justice. So as social workers, we are focused on social justice and sexual well-being, access to sexual health is a social justice issue. It fits within the scope of practice of who we are as social workers. So who gets to be sexual? That might be an interesting question. Who gets to be sexual in the world? And that really speaks to this idea of social justice. Because if you look at who is allowed, you can see the oppression, the privilege, the power, because oftentimes the people who are given permission to be sexual fall into certain categories of privilege. They're heterosexual, they're men, they're white, they're married, they're young, they're fit. Anybody who doesn't fit into that category is kind of othered. They're kind of thought of secondly, or they have to fight a little bit more, a little harder to get acknowledged or have access to care. And if you have an intersection of you're disabled and a person of color and a woman, it becomes even more difficult to access and have services that address you and address your right to sexual health. So again, just to share, sexual justice and social work. How am I doing on time, Candice? All right, okay, good, wonderful. The other thing is clients, patients want to talk about this. And unfortunately in our healthcare system, they don't have very many options. Believe it or not, medical providers are not really trained in the comprehensiveness of sexuality. They may be trained around reproduction, but oftentimes they're uncomfortable. And if you throw in certain communities, they don't get very much training around very specific communities. And same goes with nurses. So if our clients need and want to talk about the ramification of a prostatectomy after cancer surgery, or a double mastectomy after treatment for cancer, who do they go to? Because yes, their medical needs may be none or be done, but their recovery and the fulfillment of who they are and being able to be in relationship with themselves in this new body, or this body in relationship with others, if that doesn't get discussed, how do they cope? How do they recover? How do they start to integrate what that is? Again, I think this is prime area for social workers. This is what we do. We connect people to resources in the community. We give basic information. We help them through shame and guilt. We are the perfect person to look at helping patients incorporate sexual wellness into their life. Okay. We've talked about client shame. I've said something about that sexual well-being is just absolutely an affirming and innate part of our client's life, and it needs to be a part of our approach to social work. Finally, it's a part of our ethics. If you're joining this club called social work, we have ethical obligations. And so one of those is recognizing how you work, how you are in relationship with clients. And we have an obligation to bring our best self to that relationship and provide best services. I think this is kind of wrapping up for me, just to heads up, Candice. So some pillars, some things for you to think about as you are putting together a lens. This idea of a strengths perspective, I hope you are aware of this hallmark piece of social work. It looks at the resilience and the assets of clients and helps bring that into the conversation. The strengths perspective is a counter to the traditional medical model. And so I think bringing that conversation around sexual health into client services fits very nicely in the strengths perspective. If you want to read a little bit more about that, I'll share an article with you later that I talked about regarding the strengths perspective and sexual well-being. We operate from a biopsychosocial, and I would argue it should be sexual, biopsychosocial, sexual, and spiritual lens. Okay, I think the biopsychosocial lens is what makes our approach unique. We're looking at these different spheres from perhaps a medical provider, which may be only looking at a biological aspect. We're looking at all these aspects. And I think including and recognizing the importance of the client's sexuality, in addition to their spirituality, is central to the way that we see people. It's the way that we see our work. Sex positivity. This is the idea that sex is good. You know, our sexuality is an asset. It's a fundamental, innate part of who we are, and it's not all doom and gloom. Okay, that we need to be able to bring that conversation, bring to the conversation this notion of sex positivity. Just thinking here what I have left here. Oh, so if you're wanting to take next steps, what I might suggest to you is do a self-assessment. Do a self-assessment. Some of you are already starting on this journey. Some of you have made leaps into this journey. But one of the things you might ask yourself is, where are you at regarding knowledge? Sorry about that. Where are you at regarding skills? Where are you at regarding comfort? And ask yourself where you are in specific areas. So where are you at regarding knowledge around disability and sex or comfort? Because those scores could be different. And that gives you a sense of where you need to do your own work, okay? And as social workers, we're very used to reflection. We're very used to asking ourselves, what am I bringing to the table? What are my values that may be enhancing this conversation or shutting it down? How does my religion of origin, if I was raised in a faith, maybe I don't continue that faith, but how does that faith guide the way I'm looking at this conversation? Do I hear my grandmother whispering in my ear, "That's dirty, don't do that, don't talk about it"? So you need to do a reflective, critical look at your positionality as a social worker. We all have a positionality regarding this topic, and it can get in the way. And if it is getting in the way, I would argue you have an ethical obligation to address that. Hopefully, before a client decides to vomit all over you some real trauma and some real challenging conversations, okay? Finally, I think you need to really commit to looking how you're going to increase your sexuality literacy. How are you going to become more informed? And there's all kinds of ways you can do that. Everything from reading articles, but to taking workshops, finding out who in your community, like Candice, is doing that work. Can you find a formal mentor, or can you just kind of maybe stalk a little bit people who are out in the community doing what you want to do, and take workshops that they're putting on? These are important things that you could do to help elevate your sexual literacy. It doesn't have to be a big course, but it could. There's professional organizations that you could be a part of if you wanted to. But you need to recognize that having a little bit of this information and being able to at least be askable is your responsibility. I don't have to be a drug and alcohol expert. But if I'm a social worker, I should know where the local AA meeting is in my community. I should know perhaps who are sexuality rehab clinics in my area. Okay? Those are important aspects of me being a diverse social worker. So these were the key points that we covered. Hopefully I didn't go too terribly fast, but I promised you some resources. So these are a couple of book chapters that I've written on the topic. And here are some articles around the topic. This could get you started around the conversation. And if you have questions or you want to get in touch with me, by all means, feel free to reach out and I'd be happy to chat with you more.
Stalk George from afar.
I'm sorry?
I said we can stalk George from afar.
There you go. Did I manage to fit that into my allotted time?
You were beautiful.
All right.
That was great. Thank you, George. Now, of course, since we've been chatting, what did I do with my PowerPoints? You have so many really wonderful things there that I wanted to like jump on and talk all about, but I will stick to what I prepared, at least for now, and we'll come back to it. The only other thing I would maybe add to your 7 is number 8. It's a human rights issue as well. So, and when we're talking about the role of social work and within like a human rights framework, that's definitely where sexuality fits. Okay, let's actually share a screen. Oh, it started me at the end. Well, that was like, you got the end story, where we're going to end up. Now I'll take you back to the beginning. Okay, so continuing on from what George has shared with us, which has already been so fabulous. I guess my interest into sexuality came a little bit slower. Like I've only more confidently stepped into this space in the last couple of years. And my career was more in child protection. So I was working, the first few jobs I had was as a disability support worker for women with an intellectual disability. And when I think back to that job, we were doing sexuality stuff all the time. I didn't know it. And the things that we were doing in the like early 2000s to what we would do now is totally different. Like there was kind of compulsory contraception, whereas we wouldn't necessarily do it like what we did do back then. There was all these intricate relationships happening at the sheltered workshops and how we kind of manage those environmentally, behaviorally, cognitively. But that was sort of my beginning stages. And then the last 16 to 18 years, I've predominantly worked in the area of spinal cord injury rehabilitation. And so if you know anything about the role of the spine, it is like the thing that brings the messages from the brain to your body. The spinal cord is your motor, sensory, it's the computer base for your entire body. And so, the spinal cord actually is what controls your bladder function, your bowel function, your sexual function. So by, I guess, being in the spinal cord injury space for such a long time, the patients have demanded it from us that we become competent in talking about sexuality, because I guess it's quite a gendered area of health. Like we know that 3 out of 4 of our patients are going to be guys, and they're predominantly young guys. And kind of like what George was saying in terms of who is it that's allowed to be sexual. Well, we definitely allow young men who are adventurous and more likely to be risk takers to be sexual, and they are also the ones that will say, a couple of hours post injury, so can I have sex again? And they want to know, and they want all of their team to be comfortable with this. So I think depending on the areas that you work, it'll either be subtle or in your face, but it is 100% a part of our role as social workers. And just kind of continuing on from what George was talking about in terms of we work within this biopsychosocial, spiritual, sexual model. And the reason we have talked about spirituality a few times here, it's like if there's 2 areas that you want to upskill as a social worker, it's spirituality and sexuality. They're the 2 greatest taboo areas. And if you're comfortable here, you're comfortable anywhere. If I am a social worker, I am a sex therapist, I'm also a minister of religion, I'm a pastor of a congregation, I'm a mother. Like I have many hats and layers, but if you are happy talking about spirituality, you'll be very happy talking about sexuality, and they do intertwine. So that's my little plug to go and become not only sexually literate, but spiritually literate as well. So we have, I guess, already talked about that sexuality and sexual wellbeing is a human rights issue. So I guess that's the answer. Sex has to do with social work because we uphold human rights, we remove barriers, we ensure people are able to live their live and enjoy those rights. And I guess that's where my lecture finishes for today. So, but I have prepared a few other things, so we'll cover those as well. So you might want to learn how is it that you can talk more confidently about sex. So I'm going to walk you through some of the terminology that we use, some of the models to help you address sexual well-being and sexuality in a clinical setting. I've brought in a couple of case studies because I thought that might help us just to sort of conceptualize what we're actually talking about here. And I guess one of those case studies is from my social work only days to kind of help you understand what my role looked like then. And then another is from my psychosexual therapy days, so you can understand how some of those interventions sort of shift and change, and I guess just have a little insight into sort of what these sort of overall interventions actually look like. So let's just have a little reflection for a moment, thinking about your own life. Who is it that you've been able to speak freely about sexuality with? What are the characteristics about that person that made them approachable? Someone who has made you feel safe. And if you've had no one, then why? What's put you off? And then the next part to that is, do you have the characteristics that make you approachable? The things that you have been able to recognize in somebody else that has made you feel safe to talk to them, free to talk to them. It's been a fun conversation. It's been a safe conversation. It's been an informative conversation. Are you any of those characteristics? And this is almost like a journaling exercise for you to can do after this session. I want you to actually write a list of the characteristics of the person that you felt safe with. What was it about them? Was it their body language? Was it their eye contact? Was it the fact that they appropriately dropped the F-bomb in the right spot? Was it something to do with the worldview to which they move through the world? Is it just, you want to be very specific about the characteristics that those people have had that have made you feel like they were someone that you could safely talk about your concerns or even just chat with. And then that self-audit piece that George was talking about, include this next bit to your self-audit. Do I have those characteristics? And where is it that I need to sort of do my work? I'm just going to continue on from what George was talking about in terms of sex positivity. So it's a value system, and with it, it links what is known as pleasure activism. So pleasure activism is, it sees pleasure as an act of resistance, a transformative and liberation act. So one that can change lives and society for the better. It sees sex and sex positivity as essential and informed by human rights. But for those new to this, it's a little easier to digest than like a full human rights document that I could go through. But sex positivity goes further towards the positive in a practical sense. It can be like a practical expression of upholding human rights. So the sex positivity definition comes from the International Society of Sexological Medicine. It says, for most, it involves having positive attitudes about sex and feeling comfortable for one's own sexual identity and with the sexual behaviours of others. Overall, the concept of being sex positive involves understanding your own sexuality and what it means for you and your relationships. So this is the personal internal work. And then these following points come from that definition. So sex positivity is open to actively talking and learning about sex and sexuality and feeling comfortable talking about it. It's about understanding and respecting the importance of safer sex. It considers sex to be a healthy and normal part of life, which should be enjoyed. It acknowledges that people may not want sex and they may not want to have sex with you. And they may not want to have sex with other people. It accepts others' sexual practices if the participants are consenting and feel safe without any moral judgment. And it accepts others' sexual orientations, gender expressions, their experience and identities, and their lifestyles without judgment. So in short, it pretty much comes down to sex is nice and pleasure is good for you. It's the simple definition. So pleasure is something that we all feel in one way or another, and it means different things to different folks. And we tend to romanticize and focus on suffering and struggle, particularly in our health system. You know, we kind of ask people on a scale of 1 to 10, how's your pain? Like again and again and again, but we never ever say on a scale of 1 to 10, how's your pleasure? So I think that there's just this mindset that we also need to shift, that we need to include an understanding that pleasure is essential. And it can be transformative, it can be healing. It's totally correlated with the personal, the sexual, and the relational satisfaction. People may not, people may need a little bit of help getting in touch or back in touch with this, depending on what's happened as to why maybe they've come into contact with social work. And it can be radical, especially in regards to certain cultures and social belief systems. So considering this definition, consider this for yourself. Do you think you are sex positive? So we're going to launch straight into addressing sexual well-being and sexuality. We're just going to talk very explicitly right now. So the Plicit model, was developed by Jack Anon back in the 1970s. It is probably one of the most well-known visuals. It kind of looks like Maslow's hierarchy of needs upside down. And I guess the most important thing is to just start here at the top. So permission. So Plicit stands for permission, limited information, specific suggestions, intensive therapy. And when we look at permission, where it's often people just need to feel allowed to have a concern and a need, and they need to talk about them in private to someone that's empathic, non-judgmental, and that's enough. And we can all do that, you don't need some special postgrad to be able to do this work. It's seeing the person, the whole person, and seeing that sexuality is an integral, important part of them. And it's not split up into different professional hats. It's like what George was saying, it's not the doctor's job, it's not the nurse's job, it's everybody's job. To see the whole person and to give permission to raise sexual issues in the context of whatever's happened. So due to sexuality being a sensitive subject, I guess some people can be very cautious about discussing it. They're worried that, what's going to come up. Nobody wants to be the person that opens up Pandora's box and doesn't know what to do with it. Like, I have been that person. We can talk about it in a bit. It's not an uncomfortable feeling to know that there's this huge problem and you don't know what to do with it. You don't even know where to start. And I guess on the flip side, clients might be shy about bringing it up. It may not be, like for us in the rehab setting, people might be saying, you got other things to be worrying about. You need to be worrying about your physical recovery, or you need to be worrying about this or that. And it's like they are almost a bit embarrassed that it's become such a pressing priority issue when everyone else around them saying you got other things to think about. And I guess at the permission level, you don't need to fix any problems. You're just talking. And that's within everybody's scope of practice, to hear somebody's concerns, to empathically respond. And it's important that sexuality and sexual problems, you need to acknowledge that they can occur for anyone. It's indiscriminate. And therefore you need to talk to everyone, not just the white men, not just the complex clients, maybe who have like a behavioral component with it. Limited information is the next step. So that refers to the general knowledge within our specialty areas regarding sex or sexuality. So for social workers, it might be talking about, returning home, and particularly in our setting, if someone's been in rehab for a few months, how do you feel about coming home? Are you worried about anything? You guys haven't even slept in the same bed for the 6 months that you were in the rehab. How do you feel about that? And just, I guess, going here into the limited information for nurses would look different, maybe like the medication side effects from there, just some basic information. And then when we come into specific suggestions, that obviously comes into your scope of knowledge. It's a major factor. And where I sit in my specialty service, the sexuality service, we do the specific suggestions and the intensive therapy. So that's a more in-depth psychosexual therapy. We also do the biomedical interventions as well. And it requires more specialist training at that kind of top end. So I think one of the questions was, can social workers work as a sex therapist? And so in short, social workers can't graduate from social work and be a sex therapist, but social workers can work in the area of sexuality. And we, with post-grad training, like myself and George, like in terms of more additional human sexuality training, absolutely make the best sex therapists. But that's because we see people very holistically. Okay, so you've had this little understanding of the Plicit model. There's expansions on this. I'm going to just quickly talk you through an updated version, which is the explicit model. So it just adds this kind of non-linear nature that things change. So it's not a one-time intervention. You requires ongoing review and reflection. You offer to talk about a sexual problem once with somebody. That doesn't mean that you don't ever do it again. It kind of allows this sort of reflexic and cyclic kind of component to your interventions. But the difference with the extended Plicit model, explicit, is that it brings permission is a central aspect. So you come back to permission at every stage. So do you want some specific information about that concern you had? Would you like me to refer you onto somebody else? It's kind of this continually seeking permission and as the interventions extend. It also includes this external aspect in the outer circle, which refers to the clinician factors as this ongoing process that we need to develop self-awareness, reflection, reviewing knowledge, education, challenging our assumptions. And that hopefully by attending this course and other training, you're going to address some of these aspects of the outer circle as you kind of grow and learn more and actually just try and do the work. And then third, this one comes out of nursing. It's called the BETTER model. And it's just another one to kind of help you, acronyms are great. They kind of stick in your mind. So the BETTER model just stands for B, bring it up. It's the same as permission. So you bring up the issue of sexual functioning. Explain that sexuality and function can be an integral part of having quality of life. T is tell, so provide with the information and resources and be prepared to search for them and to go away if you don't know the answer and find the answer and come back. T is timing, so about the appropriate timing, and that we're guided by the clients for that. E is to educate in the context of, the illness or disability. This is, like I said, came out of nursing, so it's definitely got like that medical kind of background, particularly in health areas that have a direct impact on sexuality. And then R is around how you record and refer the information so that we document well, that we've had conversations, not explicitly about what, but that you've gone there and that we consider the specialist or the multidisciplinary team's role in kind of addressing whatever the concerns are. So there's some models for how to do it, like in terms of just how to conceptualize in your mind some of the steps. But I find some people are still a bit mute. It's almost like you don't know what to say. If you need like a really good opener. And if you have a confident first line, then you can kind of get the question going. And I think one of the things we talk about a lot is, should you have a screening question, like in your psychosocial assessment? Do you have like a little box that says like sexuality? We do at our hospital because we all acknowledge it's really important. And so we just write, sexuality on the psychosocial. And then the script that we have is like thinking about when you're asking someone about their income. You don't start off saying, how much do you earn? You start off by saying, do you have any financial stresses? Is there anything that's worrying you at the moment? Like since you've had this accident, you've been in the hospital, has it affected your income? And so you kind of get there, but gently. It's the same thing for sexuality. You got to be to the point, but you also don't be like, you still need to be skilled in that. So some of the ways that we talk about it is you could do it as a declarative. So we know after whatever condition, people have changes with their sexual function. And if you have any questions about that, I'm happy to talk to you or put you in touch with somebody else. So you've just put it out there. It's like, if you were working in any area of health, you could just insert that condition. But then even if you were working in out-of-home care, we know teenagers have questions about sex and sexual function. I'm happy to talk to you about that, or I could put you in touch with somebody else. Working in drug and alcohol, we know that people often partner drugs with sex. If you've got any questions about that, I'm happy to talk to you about that or put you in touch with somebody else. Like you really could, I've said insert condition, but the reality is you can insert any situation. And then the other alternative way is to do it like a question. So we know a lot of people have changes in their interest in sex or the way they experience themselves sexually after their insert whatever. Have you noticed anything for you? Would you like to talk about it? So this is just, I guess, some examples of how you actually do permission giving. And so that's all well and good. You've put it out there and then they come back with something. And one of the ways that we suggest you might want to consider it is a very normal response. It's another acronym. A very normal response stands for affirm that it's an important issue and relevant to their quality of life, their healthcare, their like whatever situation is that you're working in. Then V is to validate. So you want to validate their experiences, any distress or concerns that they have. N is normalize. So you're normalizing their experience. You're explaining that they're not alone, that what they're experiencing is common, that you can help them. And then R is this refer. So you consult with the client as to their preferences for how it is that they'd like to take further action, whether it's you that follows up or whether you refer on. You kind of educating them about what their options are as well. So this is like a really quick snapshot for you, hopefully to build some confidence that if you were to, bring in this sort of component to your practice, which we all should be doing, that you're not left with nothing. And that if you were to ask about it and somebody responds to that, thank them for sharing, affirm what they've said to you, that it's, and really validate that it's got an important place for the work that you're doing with them. So I just want to talk you through a case study this is when I was a social worker full-time, rather than at the moment I'm kind of straddling two roles, but I'm always a social worker in my heart. And I think I was a few years out of uni. I was probably about 10 years out of uni. The job I was doing at the time was as a social worker in a community health service. And so we would see people at home after they'd been discharged from hospital. And I remember going to this person's house in particular. He was young, 27-year-old. He'd had a spinal cord injury. He was living with his girlfriend. They had this little puppy in this like rental accommodation that they'd found. He'd had this push bike accident. Young banker, good job, about to return to work, really supportive employer. He'd had this 4-month hospital admission, and not one single person had spoken to him about sex, sexuality, or his concerns. And maybe he was able to sort of sweep that under the carpet whilst he was in the hospital. But when he got home, it became like this really front and center issue that he was left with a sexual dysfunction, which I know is just one area of, sexuality. But to know that someone has a spinal cord injury, that they have a sexual dysfunction, and you do not talk about it is like criminal negligence, in my opinion. But from that, sitting in their lounge room and talking to them about their concerns, the thing that has triggered to me is if they aren't talking to the young, white, straight men, you can guarantee they're talking to nobody. So if you are working with guys who have not had any sexuality education information, then really think about what's happening to the women and what's happening to the older people and what's happening to anyone culturally, linguistically diverse, or maybe don't speak English. Like the group who are going to get the education from the doctors and the nurses are the young, white, straight guys. And if they're not getting it, then no one's getting it. And that, I think as social workers, we have this kind of responsibility to indiscriminately include sexuality in our assessments. And so because ours was on our form, it prompted me, like I'm talking about his, return to work, his return home, how was his kind of, settling in with his bladder management, his bowel management, did he have everything he needed about his sexual function, like assuming it had been addressed. But because it was in my initial assessment, in my psychosocial assessment, I knew that I wouldn't miss it for anyone. So that was, I guess, it's just like an example of the reminder for why it is that we have sexuality included in our assessments, because for some people, you might think it would be obvious that they would have had education, but they've completely slipped through cracks. And the distress that he and his girlfriend were experiencing was so significant. It was like, yes, to fall into a stereotype, they're young, they're in their prime, but at the same time, they now had this major part of the communication in their relationship was muted. And all the things that sex had meant for them in terms of how they interacted, how they bonded, how they forgave each other, how they made up, like that was suddenly changed. And they didn't have a replacement language for how to say, I'm sorry, I forgive you. And I just think understanding the role that sex plays in relationships is also a really important part of our social work interventions. So this second case study I want to talk through is one from just this year. So obviously learned a little bit over the last few years. So this guy was injured back in 2015, another spinal client, but I guess the reason that he was referred was to explore his sexuality and develop his intimate relationships. He was a single guy. He'd gained a lot of weight since his injury. He had secondary conditions of depression. He had lots of lower limb pain, social isolation. The progress from his referrer, which was one of his physios, was kind of saying that he'd had this sort of recent improvement with some of his sensation, bladder and bowel function. So it was, I guess, in the context of as his injury and recovery was changing, so was his interest and explicit searching for answers around his erectile function specifically. So he was somebody that we saw in person. It was before lockdown. Now we see everyone on Zoom. And NDIS funds this work. So I think that's the other thing to remember, that systemically sexuality is funded. So we also need to be in this space to help. So in his assessment, he'd not done much solo exploration. I mean, 6 years post-injury, he had really not done anything. He was open to the idea of seeing a sex worker. His goal was very function. So he was very outcome focused, which is a big part of our work, is to try and expand that, but we'll go into that another day. He wanted to improve his erectile function. He wanted to be able to ejaculate, and he wanted to he had trialed some of these PDE5 medications like Viagra, Cialis. I'm getting very technical, but there are options for people. He wanted to improve his ability to socialize and meet intimate partners. His confidence had had a massive knock, so he wanted to address that as well. So you can see, even in a sexuality specific referral, there's so much more than just sex. And this is, I guess we always say to our doctors when we do their orientation, they're like, because they all say to us, oh, this person's in a relationship, or that person's not in a relationship, they don't need to see you. And I'm always like, don't assume that because someone's not in a relationship, they don't need to see us, or they don't need to have somebody talk to them about their sexuality. So that's like another kind of unconscious bias. People see people in relationships and think, oh, it might be a problem, but they see a single person and they ignore it. So for him, his intervention was counselling, a lot of talking around adjustment to his isolation, to the way that was that he could meet people and break up this internalized ableism that he was holding as well, about what his life was like before and how it should be. Lots of education about sexual function, spinal cord injury, sexual scripts, and moving towards this sort of pleasure focus rather than necessarily ejaculation or function focus. We talked about sexual aids, and that's a lot of the work that we do now, particularly in this area, like, and how people can improve their function. And then a lot of work with his physio around his upper body strength and kind of his mobility and bed mobility. And ultimately, through lots of interventions, it progressed to enough confidence to initiate establish a relationship with a partner. And I guess just sort of being able to recognize, even after such a severe injury, when sensation changes, yes, pleasure is possible, and sexuality is an enormously important part of life, and that we shouldn't just be kind of seeing people as this, you know, they have a disability, therefore they're asexual. So if that is your current thinking, then lots of reflection on that. So they were just, I guess, two to try and help you fathom maybe what does work in this area even look like. But I was hoping that maybe we could brainstorm maybe on the Q&A that might help. On the chat function. So what are the areas that social workers typically work with clients when it comes to sex and sexuality? And the ones off the top of my head to kickstart our conversation is all areas of health, ideally. If you are coming through a hospital, then you should be seen. If you're coming through a community health service, then it should be addressed. But we know that less than 15% of health professionals feel comfortable talking about sexuality. So we know that there is not a lot of that happening. But if you want to, we could just think about cancer and the impact treatments have on sexuality and sexual function, intimacy, the way someone sees themselves, any acquired disability. I'm not going to sit here and list them all, but obviously social workers who work in the area of disability have a really important role when it comes to sex. It's almost like a sexual advocate, like to allow people to access the rights. And we do some training around working with sex negative supports, because I think sometimes that is the biggest barrier. Like one of my clients, she can only have a wank on a Saturday because she's only got like one support worker who she feels comfortable with. So it's only when that person's on shift. So if you kind of just start to think through the logistics of how hard it is for some people when they have all these negatives in their life. Social workers who work in the area of aged care, specifically in like residential settings, dementia, you know, sexuality should be a big part of your job. Any social worker who works in drug and alcohol, we know drug, alcohol, and sex come together. So anyone who's working in drug and alcohol should definitely be confident talking about sexuality. Any harm reduction program, any counselling settings. We get referrals all the time for people who have a psychotherapist, a psychologist, a mental health social worker, and people are just, no, actually I take back the mental health social workers. It's usually the psychiatrist as well. And they'll have a sex problem and they'll refer to us because they don't talk about sex. It's like, what are you talking about? They're already in your room. If they can't talk to you about sex, what else can't they talk about? So it drives me mad when we get referrals and they've already got 3 or 4 mental health professionals involved. And the reason they've referred to us is because of a sexuality thing, because nobody else wants to talk about it. So what other thoughts do we have? Brain injuries come up, lots of aged care, mental health. Mental health is massive. Thank you for bringing that up, because obviously the effects of the antipsychotic medications have a huge sexual function impact. massive area. All sexual health clinics, that's a no-brainer. It's in their name, right? But unfortunately, so much of sexual health clinics is focused on disease prevention, STI testing. My colleagues who work in sexual health clinics are like, we hardly ever get to talk about pleasure or the establishment of relationships and sort of, it's kind of like consent is covered, STIs, HIV management, the kind of like safe sex stuff. But in terms of anything to do with kind of confidence, skills, sexual skills, they're not taught. Anyone who works in youth work, so school settings, trauma settings, well done. Okay, you guys have got some great examples here. Pregnancy, Planned Parenthood, prison. Yes, I love it. You're all on the right page. Okay, so the majority of my client group are on antidepressants, which cause erectile dysfunction. Exactly. And then I never thought to have this discussion whatsoever. So thank you for your honesty. There's usually other more pressing issues. But I think whilst you say like other more pressing issues, sexuality is usually completely intertwined with those other pressing issues, like their depression and their anxiety and their sadness and their loneliness, and it's all interconnected. And then of course areas of like intimate partner violence as well. So thank you for your brainstorm. At this point in our presentation, George and I thought that we would come to, these are my contact details as well in case you want to get in touch with me later, but I'm about to switch PowerPoints because we thought we would come back to the questions that you guys asked in the registration of attending, and we would just work through some of those questions. If there's any specific questions that you have, now is the time to drop them into the chat as well.
Candice?
Yeah.
I thought I might just add to the piece that you were just adding there, and that was the idea of people having disclosure, like the fact that they've had a mental health stay at a hospital or they are on medications and they're single. How do they disclose to a potential sex partner? Is it on the first date? Is it on the second date? Do I talk about that I have erectile difficulties because I'm on an antipsychotic? And how do I bring that up? Yeah. Or do I talk about I've just had prostate cancer, or I can't have a firm erection? When do I? And I'm only 25, and I want to date. When do I? And no one's talked about that with me. No one's talked about my own shame, because my entire worth as a man is focused on getting a hard on.
Yeah.
And so I think these are conversations that social workers could be having with our clients.
Yeah. Preach, brother. I'm with you 100%. Okay, so some of the questions that were put to us, which are what areas do social workers typically work with? So we just answered that one. So how does sexuality impact social work? George, do you want to take that one?
Yeah, I come back to my focus on best practices. I can imagine being a social worker and not being open to this or being capable of addressing this aspect of my client. I think, again, it impacts the quality of who I am as a social worker. Yeah. And again, I don't have to be an expert, a sex expert, to be askable. And I think the idea that a social worker is open to the totality of the client when they walk in the room, who they are, and being capable of holistically, comprehensively looking at age-appropriate, medically accurate, inclusive, pleasure-centered sexuality education. I think those are again, it's just the way that I see myself as a social worker, that it's my responsibility to be versed in the human nature, the human quality of what it means to be human. And if I'm not able to understand cultural, religious nuances of a person, then I'm not really doing social work. I'm not doing it the way I envision a rich social worker does things. And if I don't understand that aspect of it, then it's my responsibility to learn. It's my responsibility to get familiar with the resources. If I'm in an area of the community that has a high percentage of a Jewish population,
you learn about Judaism.
Yeah, I'm not Jewish, but I might want to understand some of the practices. Absolutely. And understand how that impacts who I am as a social work practitioner.
Absolutely.
I use this example that when I first started out, I was a disability support professional, and one of my first clients was Catholic. I'm not Catholic, but part of my responsibility was helping him with food preparation. And every Lent, he had to observe no meat on Fridays. And so it was part of my responsibility to help him prepare meals that were in accordance to his faith. And to respect that and to understand what that meant to him and to help him, when we budgeted money, I helped him budget money for the offering plate. Yes, at Mass. Absolutely. As part of my understanding, I need to understand my client. I think sexuality falls into this.
I agree with you. I also had to support people to attend Mass. I'm not Catholic, but then having to learn all of the, what happens at communion and follow all of that tradition. There's so many things that we learn for good quality practice that this just falls into it. I think back to my undergrad days, I had no human sexuality education. It wasn't part of the course at all. So already you guys have had 2.5 hours more than I got. And the reality was I never ever touched a Centrelink form whilst I was at uni, and I never touched a housing form whilst I was at uni. And some of these things you don't learn at uni, but you learn them on the job. And so when I had clients that needed housing support, well, I got on the internet and I worked out how to navigate Housing New South Wales. It was complicated, but I learnt it. And when I needed to help people navigate the disability support pension, I jumped on the internet and I learnt it. I think there's skills for uni is great for teaching us about the theoretical frameworks which we should be practicing. And a sexual wellness lens is one of those. You've learnt that. How you actually do it is going to be job dependent, and it's also going to be context specific. And so there's some things that we do need to learn on the job. So
yeah. And I think just being available and listening and being open to hearing that, when you become informed about a way of practice, it seeps into the way that you see, the way that you hear, the way that you do.
I agree. Yeah. So this third question was, why should we practice sexuality during why should we consider sexuality during our social work practice? Well, hopefully we've already convinced you through the last couple of presentations that it's a human rights issue, it's sexual well-being, sexual justice. There's so many reasons as to why you should be, it's good practice, it's holistic practice, it's person-centered care. Is there any other reasons?
I think you caught it.
I think you're all converted now, right? Yeah, good.
And keep in mind that does not mean, again, that you're comfortable. There are times that clients ask me questions and I don't know the answer.
Yeah.
Or it's uncomfortable, But again, the more that you do this, I gotta tell people, some of the hardest conversations are suicide ideation, or when people are talking, or I'm having to have a conversation with somebody because their parenting is putting them in jeopardy of losing their children. Those are hard conversations, but they have been a part of my role as a social worker. And I think being able to wade into those conversations and even just acknowledging, I am really, really embarrassed by this conversation, but I know it's important. Or I don't know a lot about this, but I'm going to find the answer for you.
Yeah.
I had a client ask me about some club drug, and he was rambling on, and I had to look at it and I said, you might think I'm up to date, but I have no clue what you're talking about. Can you tell me?
Google that.
Yeah, I'm gonna Google that because he used, I'm like, I'm from the US. I don't know the Australian term for this. I'm sorry.
Oh man, it's so true. I had someone say to me, oh, they bought their drugs on Trick, and I was like, oh, was that an app? And they were like, no, it means like you pay for it later. I was like, oh, cool. I have no idea. I'm so uncool. But anyway, it's.
But I think that speaks to, I think clients are receptive to you being human.
Absolutely.
They appreciate your vulnerability. They don't need you to be an expert. They just need somebody to walk with them. They need somebody to stand beside them and help and be willing to listen.
My client that I guess the catalyst for me going and doing further study was feeling like I had opened up Pandora's box and I had nothing to offer them. And I looked around our industry, and I, like, within the rehab space, no one was really doing like that intensive therapy side of sex therapy. And then when I was looking, I didn't really know much about sexology as a profession. I didn't know much about the community of sex therapists, but from what little I had to do, a lot of them didn't know much about spinal cord injury. So then I kind of had this, I don't know, catalyst moment. It's like the ultimate, I don't know, but I'll go find out and come back to you. So went and enrolled in a postgrad and did like human sexuality and reproduction at Sydney Uni. And throughout that whole thing, whole 12-month full-time study, they didn't talk about disability at all. So I thought I would go off and learn the holy grail of all of the golden answers, only to find out that it wasn't there. And I think the more that I have learned about, you know, the sexuality side of things, there is no gold magic wand, silver bullet, like right answer that I just didn't know. And some of the referrals that we get are for people who are in out-of-home care, like 17, 18, 19-year-olds, who maybe have like an intellectual disability or just really complex trauma, maybe even like that, like fecal alcohol syndrome, a whole bunch of other kind of childhood awful things have happened. And the most common referral is 16, 17-year-old girl on Tinder having lots of kind of hookups. And the support workers, the NDS support coordinator, the case managers, even like, you know, the Department of Community Services, they all like, they need to have like sexuality counseling. And I kind of go in there and I'm just like, that everyone, all the health professionals are hoping that I'm going to have some magic answer that's going to A, help her start using contraception, B, maybe make her stop that behavior because that's what they all want because they're all uncomfortable with it. And I think the thing that has become more and more evident is actually, I am not the right person to be coming in to do a one-off intervention or a 2 or 3 session when this person already has 24-hour support, heaps of clinicians in their life with great relationships. And so I've kind of moved my intervention to be more like, I'll talk to the support coordinators that are in the house, and I'll talk to the social workers and the psychologists that are already involved with her in case they think that there's a magic answer. Because if they're looking for more information, I can give them more information about, you know, sex education, kind of comprehensive sexual health stuff. But there's no magic answer that I'm going to be able to do by going in when she already has this whole team around her. So I think if the people who are around her just became a little bit more confident, then she would get what she needs anyway, without referring, like you kind of want to get out of the habit of just like referring out to experts for some magic fix. When
and I want to add something. I think we live in a fantasy world that says that there's somebody to always refer to.
Yeah.
Oftentimes, as a social worker, you're the only one on the 3 a.m. shift at the hospital. Yeah. There is no one else in the hospital but you. You're the only social worker, maybe. Yeah. So I think we have to have a baseline of accountability and not think that we can just refer problems outside. And we have to be willing to tackle challenging and difficult conversations and recognize being askable is not necessarily challenging or difficult. It's part of who we are as social workers. Mm-hmm. And again, setting that tone for care teams that, you know, Mrs. Jones or Mr. Jones or whoever client A is really has a lot of experts in this room. It's a shame that they don't feel comfortable coming to any of us around this. Yeah, because there's a lot of knowledge in the room. I ask my medical students that, because sometimes they'll say, well, I you know, we have a patient, they've never asked about these things. And I said, is it they've never asked or you've never asked?
Yeah, that's exactly right. So the other question, sorry, I've just stopped sharing my screen so I could see you all a bit better. But the other question was, how can sexuality and gender diverse professionals appropriately use our lived experience to work with the LGBTQI community and individuals?
Well, I think the fact that, again, there's this concept of the use of self in social work, that we bring who we are as practitioners, as social workers, into the room. And so I think if we belong to, the queer community and we have expertise, what a gift to our clients that we understand what that is. That, I think all of my experiences, all the shit that I've been through in my own personal life, all the crap, if that can be in service to my clients, I understand what it's like to grieve. I've been through grief. I understand what it's like to be made to feel shame, and so being able to bring those conversations into our work with clients, I think is a benefit. It's ability for us to help, in a way that brings a nuance that other social workers might not be able to.
Yeah. I think that's the thing about social work, is our tool is ourselves, right? Like, we are our tool. It's not like, I don't know, a baker who has like the best oven. Like, it's us. And so we come with whatever lived experience we have, whatever previous knowledge, and for some clients we're just going to be the most perfect fit, and for others we'll just be okay, and that's fine. But it's sort of, I guess, acknowledging when you are the most perfect fit and you bring your lived experience, how wonderfully empowering. The last question, George, because I feel like we're going to run out of time, we're not going to be able to get through all of them, that we had highlighted here was, how do social workers educate themselves to challenge internal bias surrounding sex work, or working with any marginalized sexuality minority? So the examples were, the kink community, sex on premises, chemsex, so that way work is respectful and safe. So I'm just going to break that back down again. So how do social workers educate themselves to challenge internal bias surrounding sex work? I'm going to start there specifically.
Yeah, and so I think I added that, that it's how we go about addressing bias in a variety of communities, whether it's around sex on premises or chemsex or things like. I think we have to begin to understand, and we have to become allies to groups and work on ourselves around our own uncomfortableness or perhaps our own biases. I think bringing those conversations into perhaps agencies or spaces with our colleagues who are more reticent around this is that's another challenge. And I think, again, for me, the way I've accomplished this is, again, I frame it as, this is the way I view social work. For me, it's a responsibility to do best practices, and I cannot not see the sexual well-being of a client. I cannot not address that. If I see someone being sexually shamed in a group home, I have a responsibility to everyone in that group home to say, that's not okay. That's not okay. That's not how we do things here. And so, again, I think how you frame it, and I understand the conversation's really difficult for my colleagues, but that's what I signed up for. I signed up for the hard shit.
Yeah. I think recognizing an internal bias is one step, and then working really hard to work on that is the next step. And so I just want to talk about sex work for a second, and sort of I think some things are an evolution. So my first placement as a third-year student was with like an inner city community. I'd spent 3 days a week in like a transitional accommodation for people who were homeless and transitioning, like on the housing wait list, and then 1 day a week in a drop-in centre for sex workers in King's Cross. And so the role that I had there was very much like showers, food, like kind of breakfast, safety. There was like condoms on site, and it was kind of more like like a sanctuary, like a place that women only, so it was only female sex workers that could attend. And back then it was very like cisgendered, so it was only female sex workers, and the trans community were definitely excluded from that space. But the role there was kind of almost a little savior-like, to be honest, like that the sex workers needed us, that they were vulnerable, that they, and I think that was probably because it was also run by like a Baptist group, so there was definitely that religious sort of cultural component to it. And yeah, Hope Street. And I thought the work was amazing, absolutely amazing. I learned so much. But as the years have gone on and I've learned more and more, and I've met sex workers and I understand sex work industry better, and I've watched documentaries like Scarlet Road and have spent time understanding the diversity within the sex work industry, and have worked hard to, I guess, see it. It's one of those things that's rooted into news, like, so for example, New South Wales decriminalised sex work in the, like when I was on placement, like in the 90s. It was for a long time, New South Wales is like leading the way in sex work. I think understanding it from like a legal perspective, and not just my understanding from watching Law and Order SVU, really helped me kind of understand actually, like, the way that I understood sex work was really given to me by Olivia Benson and Elliot. And that is not very helpful when it comes to actually understanding the community and also understanding the diversity of the work. And now that I've specialized in this area of disability, like the role that the sex workers play in this community is life affirming, quality of life. They are like an extension of the allied health team. And so for some people, like, we just, I think, really need to work hard on these internalized bias that we might have towards a particular thing, and to really understand what, where, why, how can I learn more, and that comes out in supervision. So I think this is like maybe a little plug for why it is that we have lifelong supervision, and also just to be really kind to ourselves that when we're learning new things and we're I guess doing new things and being challenged, that sometimes the learning is hard and the evolution is hard, and to kind of look back and go, wow, I really changed, then that's, I guess, part of the development as a social worker and expanding your identity. Do you want to add any?
Well said, Candice. I think that being kind to yourself, being committed to the work, and recognizing none of us got where we are overnight.
That's exactly
none of
right.
Us. That being a social worker is an evolution. I am not the social worker I was when I first started. And I continue to grow and change and hopefully become better and more informed, and you will too.
Absolutely.
I think we might be out of time.
I think we are. So I'm just going to do a shameless plug for some upcoming education that we have running, in case you want to do some more very specific training. You can follow that link. Otherwise, the other thing I was going to add is another shameless plug, and it's a podcast that we recorded that only came out yesterday. So you might like to have a little listen to that too. This is myself and my colleague Arlen talking about sexuality after spinal cord injury. But sometimes you just need to immerse yourself in the grey literature and social media. Follow all the most sex positive social media accounts you can find. Anyway, is there anyone else? Anything else? Frankie, I don't even know where you are anymore.
Right here.
Yeah, cool. All right, that's it from us.
All right, thank you, Candice. Thank you, George. Look at all these wonderful messages of appreciation coming through the chats. I think it's been a wonderful session. Thank you so much for bringing your expertise and experience and for sharing that. So really, really warm thank you. And I hope everyone has had a good time, and I wish you a wonderful weekend ahead.
Thanks so much for having us.
Thank you so much, Georgie. It was great. Great. Thank you.
All right, thanks, everyone.
Thank you.
I will stop the recording now.
Thank you.